Welcome to this explainer. Okay, we are diving straight into the deep end today because we're going to decode the incredibly intricate pharmacological balancing act of neuroanesthesia. If you've ever wondered exactly how medical professionals keep a patient safe, perfectly asleep, and physiologically stable during complex brain surgery, well, you are in the right place. Together, we are going to map out exactly how each drug impacts the brain's critical parameters. We're talking pressure, blood flow, metabolism, the whole shebang. We'll break it down step by step so you can master these concepts without ever having to flip through a textbook.
So here is our quick roadmap for the explainer. We'll start with inhalational agents and autoregulation, move on to the halogenated anesthetics, shift gears into intravenous induction agents, and then wrap things up by looking at non-synthetic versus synthetic narcotics. Let's get right into it. All right out of the gate, we have to establish a fundamental absolute rule when it comes to inhalational agents. When we administer these gases, most of them do something really helpful. They reduce cerebral metabolism. By suppressing neuronal activity, they essentially put the brain's energy demands on pause. But, and this is a massive catch, they also disturb the brain's natural autoregulation. They actually cause the blood vessels in the brain to dilate. Now, this cerebral vasodilation increases the overall cerebral blood volume, which ultimately drives up intracranial pressure, or ICP. It's the classic medical trade-off, right?
Let's move into our first specific category: inhalational agents and autoregulation.
When you're dealing with inhalational agents, timing is literally everything. Looking at this gorgeous watercolor visual, I want you to notice a very specific clinical warning. If you administer these agents for more than 2 hours, it can actually increase cerebrospinal fluid, or CSF volume. And even more critically for neurosurgery, these agents mess with intraoperative evoked potential, or EP monitoring. When surgeons are delicately navigating around vital neural pathways, they absolutely rely on EP monitoring to ensure they aren't causing permanent damage. So if your anesthetic agent blunts those signals, you're making the surgeon's job significantly harder.
Now, let's talk about nitrous oxide, or N2O. It's a potent vasodilator that markedly increases cerebral blood flow. But here is the fascinating and frankly terrifying physics of this gas. Its solubility is 34 times that of nitrogen. What does that actually mean for us? Well, it means if there's an air pocket anywhere in the body, say inside the skull during a craniotomy, nitrous oxide is going to rush into that space 34 times faster than the nitrogen inside the pocket can escape. This expands the air pocket rapidly, creating a massive risk for a condition known as tension pneumocephalus. To prevent this expanding pressure bomb from becoming trapped inside the patient's skull, it is a hard and fast rule that you must turn off the nitrous oxide about 10 minutes prior to dural closure. Oh, and as a quick side note, it also contributes to post-op nausea and vomiting.
Moving right along, let's explore Section 2, the halogenated anesthetics. Let's put two powerful halogenated gases head-to-head, isoflurane and desflurane. Now, they both suppress EEG activity, but they differ drastically in their physiological side effects. Isoflurane is highly protective. It can suppress brain activity all the way to a flat line, literally an isoelectric EEG, without causing metabolic toxicity. In fact, it actually improves neurologic outcomes in cases of incomplete global ischemia. Basically, if the brain is starved of oxygen, isoflurane is your best friend. Desflurane, on the other hand, acts as a cerebral vasodilator. It dangerously increases both cerebral blood flow and intracranial pressure. It does decrease the cerebral metabolic rate of oxygen, which then leads to a compensatory vasoconstriction, but honestly, that overall profile makes it really tricky to manage when a patient's ICP is already a major concern. Then we have sevoflurane, which kind of sits in a league of its own. It only mildly increases intracranial pressure and cerebral blood pressure, all while still effectively reducing the brain's metabolic rate of oxygen. So it seems like the perfect middle ground, right? Well, you have to watch the heart. Sevoflurane acts as a mild negative inotrope. That means it weakens the actual force of the heart's contractions. Because of this, cardiac output just isn't as well maintained as it is with isoflurane or desflurane. All right, shifting gears away from the gases, let's step into Section 3, intravenous induction agents, and see how these tweak the brain's internal dials.
Let's start with the absolute heavyweight champion of IV anesthetics, propofol. Believe it or not, its exact mechanism of action is actually still unknown, but clinically, propofol is a total powerhouse. It has a super short half-life and 0 active metabolites, meaning it clears out of the body incredibly fast. This makes it absolutely perfect for total intravenous anesthesia, or TIVA. And crucially, it causes a highly predictable, dose-dependent decrease in both mean arterial blood pressure and intracranial pressure. You lower the dose, pressures come up. You raise the dose, pressures go down. It's incredibly reliable. Moving on, this beautiful watercolor visual breaks down the pharmacology of barbiturates and narcotics in a neurosurgical context. We're about to explore exactly why some of these drugs are strictly avoided while others are highly preferred. Let's look at the barbiturates first. These drugs are phenomenal at producing a significant reduction in the brain's oxygen metabolism, and they even act as scavengers for harmful free radicals. However, there's a really serious clinical trade-off. They cause myocardial suppression. This leads to significant hypotension or low blood pressure, and if your blood pressure drops too low, you severely compromise the cerebral perfusion pressure. Basically, you just aren't pushing enough blood up into the brain to keep it safely oxygenated. This cardiovascular trade-off is super obvious when we compare etomidate and ketamine side by side. Etomidate is an anesthetic and an amnestic, but it provides exactly zero pain relief, no analgesia whatsoever. It also has this bizarre side effect of producing myoclonic activity, muscle jerks that can easily be confused with actual seizures. Plus, it can impair renal function and cause adrenal insufficiency. Now contrast that with ketamine, which is an NMDA receptor antagonist. Ketamine produces a dissociative anesthesia. But unlike etomidate, which can drop your pressures, ketamine aggressively increases heart rate and blood pressure and dangerously spikes intracranial pressure right in parallel with cardiac output. Because of that massive ICP spike, ketamine is typically a huge red flag in neuroanesthesia. Next up, we must examine the narcotics, starting with Section 4, the older, non-synthetic compounds that carry some really hidden risks. Okay, here is a hard and fast baseline rule for narcotics in neurosurgical patients. Every single narcotic causes dose-dependent respiratory depression. If a patient is awake or simply not mechanically ventilated, they are going to breathe slower and shallower. This inevitably leads to hypercarbia, which is a buildup of carbon dioxide in the blood. And why does that matter to us? Well, because elevated CO2 instantly causes the blood vessels in the brain to dilate, resulting in a concomitant sharp increase in intracranial pressure. Let's step through exactly why morphine, a classic non-synthetic narcotic, creates a literal danger cascade in neuropatients. Step 1. Morphine triggers histamine release in the body. Step 2. That histamine causes profound hypotension and cerebrovascular vasodilation. Step 3. As we just learned, dilating those blood vessels directly and immediately inflates the intracranial pressure. And finally, Step 4. You now have a patient with dangerously low systemic blood pressure, but really high pressure inside the skull. This combination severely compromises cerebral perfusion pressure, effectively starving the brain of the blood flow it desperately needs. Plus, there's a serious metabolic trap with morphine. If your patient has failing kidneys or a bad liver, renal or hepatic insufficiency, the drug's active metabolite, morphine 6-glucuronide, isn't cleared properly. Instead, it accumulates in the system, creating massive postoperative confusion. And honestly, the absolute last thing you want after brain surgery is an altered mental state that masks whether the surgery was a success or if there's a new neurological complication developing. To avoid that whole histamine nightmare and the unpredictable metabolism of morphine, we look to Section 5, synthetic narcotics, though, as we'll see in just a second, these two require some really precise selection. This table lays it out perfectly. When we look at our synthetic options, remifentanil is amazing. It safely reduces metabolism, blood volume, and ICP. And because it clears so incredibly fast, it is the absolute go-to choice for an awake craniotomy, though you have to be careful because large doses can be neurotoxic to the limbic system. Fentanyl acts similarly. It easily crosses the blood-brain barrier and safely reduces those exact same parameters. But I want you to look closely at that last row, sufentanil. Even though it is significantly more potent than fentanyl, it unexpectedly raises intracranial pressure. This is likely due to its hypoventilation effects. Because of that specific spike in ICP, sufentanil is generally a hard no. It's usually not appropriate for neurosurgical cases at all. So, we have covered a ton of ground today. We've mapped out exactly how gases, IV inductions, and narcotics all pull the various levers of blood flow, metabolism, and pressure inside the skull. So I want to leave you with a final thought to ponder. Knowing that every single milligram shifts the delicate balance of pressure inside a closed skull, which specific combination of these agents would you trust if you were the one waking up during an awake brain surgery? Take that question with you and keep exploring. Thanks so much for joining me on this explainer, and I'll catch you on the next one.